Assalamu alaikum wa rahmatullahi wa barakatuh. I would like first of all to thank Professor Hussein Al-Amin for the invitation, and thank you, Professor Ibrahim, for this introduction. So my task today is endoscopic treatment of benign refractory esophageal strictures. I'm going to speak mainly on refractory esophageal stricture, which is one of the really very important and very difficult to be managed. These are my objectives. Refractory stricture definition, etiology, technique of the standard treatment, which is the dilatations, and then we will go for the advanced incisions, injection with steroid or mitomycin, then a stent, and if we fail, what to do for our patients. So this is one of our patients who presented with corrosive injury, and after 6 weeks, he came with severe strictures, and after 5 or 6 dilatation again. Whenever we go, I went for this patient to 17 millimeter again, and whenever we go, we are seeing the same stricture. So this is one of the really very difficult especially with corrosive injury. The etiology of the esophageal stricture are many, and the most important, the refractory, you can see it in the peptic strictures, eosinophilic esophagitis, sometimes if it is chronic, caustic injury, radiations, and post-esophagectomy, which is really sometimes very, very challenging. Classification of strictures, very important to know the classification of your patients. The dysphagia scoring system, it will tell you how bad is the strictures, benign versus malignant stricture, very important, especially if you are seeing the patients from other referral, malignant, until proven otherwise. Then once you sure that it is not malignant, then you will go for the dilatation. And if it is benign, is it simple or complex? The stricture severity, you can assess by endoscopy directly, and of course the definition of the refractory. The dysphagia scoring system is very important. Say, for example, if you have a patient who is unable to swallow liquid, so this is a really difficult case, like our patients. The stricture severity also, you can assess it easily by the endoscopy. If the scope busts without resistance, this is mild. If the scope busts with resistance, this is moderate. And if you cannot bust the scope, this is a severe stricture. Simple stricture, a short, symmetrical, straight focal. Usually you can see it in Chasky ring and esophageal web. Most of those cases.
Dr. Khalid, what the scope? What the diameter equal? You said your scope can pass. Yes, this one, yes.
10 millimeter.
You should set that.
Our scope is usually 9 or 10.
But,
so
but because this classification, you should put the 9 or 10.
This is a rough idea to tell you about the stricture. So if your scope is passing, this means that it is mild. If it is resistant while you are passing, this is moderate. And if you cannot pass, so this is
normal scope, normal 10.
Yes, normal scope, yeah, normal scope.
Thank you.
So simple stricture, as we said, most of the time, 1 or 3 dilatation, those cases, they will be done. But sometimes you, in 25%, you need to go up to 5 sessions, and resolution of those simple stricture usually 95%. Now, complex stricture usually iatrogenic, anastomotic, caustic, like our patient, radiations, usually more than 2 centimeter, angulated, severe, narrowed strictures, asymmetrical, irregular, tortuous, more likely to be recurrent and refractory, and usually difficult to manage. The definition of benign refractory esophageal stricture, inability to dilate to 14 millimeter over 5 sessions at 2 weeks interval. And the recurrent benign esophageal stricture, the definition is inability to maintain a satisfactory lumen diameter for 4 weeks once the target diameter 14 millimeter has been achieved. So what's the aim of endoscopic management is to relieve the symptoms of dysphagia. So if you have a patient without any dysphagia, whatever you are seeing, no need to be dilated. So dilatation is mainly for patients who have dysphagia. So this is the patient, you can see very tight strictures. For this patient, sometimes I use the direct catheter of the ERCP. You can see, you can put it, you can put injection, you can put the contrast, and then you can put your guide wire easily. This is one of the things that it can help you during the dilatations. So this is the bougie. You can see, always try to use the X-ray, and you can see that this is the contrast which we injected, and you can see the marker is going down to the stomach. One of the important things with the bougie is don't use it when you have contracted a small stomach, because of the distal tip that it can injure the stomach. So this is post dilatation. You can see very nice dilatation, and you can see there is a good tear, and the scope is passing, and you can see here, this is the nice tear, and but the patient didn't also improve. We went again for the other modality. So the esophageal dilatation general tips, both whether a balloon or bougie are equivalent. They have equivalent outcomes. Both have equivalent safety. The complication of perforation 0.1 to 1.1%. The success rate is 70 to 90%. But the problem with the balloon are more expensive than the bougie. Savary or wire-guided dilatation, always use it for complex stricture. Fluoroscopy is not mandatory, but when you have complex stricture or difficult, you need to use the fluoroscopy. Not wrong to dilate until the tear occurs. So very important. Once you have a good tear, this means that you have a good dilatations. Ultrasonic or pediatric scope is very helpful if you have it in your unit, or you can use the catheter to delineate your guide wires. Important questions when you are dilating, when to start the dilatation, of course, after healing of the inflammation of the ulceration, because once you are dilating with the ulcer, the perforation risk is high. At what frequency do we dilate? Every 1 to 3 weeks. What are the dilator of choice, bougie or balloon? Both of them, they are equal, but sometimes some people, they prefer this or that, but if you will come to the evidence, both of them, they are equal. What is the target diameter? 13 versus 15 or 16 versus 18. So usually, if you have refractory and a recurrent, usually 16 is better. Start within 1 to 2 millimeter larger than the estimated lumen. Of course, we follow rule of 3 and rule of 2 for eosinophilic esophagitis because of the risk of the perforations. The X-ray is very important. If you have it in your unit, you can see that the disappearance of the waste, and you can see your situation in elegant way. This is again another patient who came to visit Dubai. You can see that he had impaction of food, and we tried to dilate him several times. And this is, I think, the third or fourth time. And he used to drink mainly fluid and soft diet. So once we dilated once, he used to come again for the, you can see the esophagus. His esophagus is tube-like, and his age is 74, so he used to come again for the dilatation. So this is, I think, the third or fourth dilatations. You can see this is this case I used the balloon, and then after that you can see after the dilatation. He had multiple level of stricture. All of them, we dilated them from the upper, mid, and lower esophagus. You can see here, I'm trying to induce a scope. So this is the proximal one. And then if you will go down there deep, you can see the other tier here. You can see them, and the patient did fine. So the endoscopic dilatation of benign esophageal anastomotic strictures over 16 millimeter has a longer lasting effect. And if you will see the period overall dilatation free period, you can see it with 18 millimeter is longer and better. And maybe some people, they are afraid about the perforation, but if you will see the 18 has only 1 perforations versus 7 in the 16. This is again another study came this year. Comparing 13 to 15 versus 16 to 18. And from this, because of the dilatation up to 16 to 18, diameter was associated with fewer endoscopic dilatation sessions during the follow-up. So they suggest to go 16 to 18 in the refractory cases. Steroid injections, triamcinolone, 10 to 40 milligram. for those who are not responding to dilatations. So that's this patient. We went again with injection of the steroid. You can see we injected in 4 quadrants and many levels. The intralesion steroid benefit of in benign refractory esophageal stricture. This is a meta-analysis comparing the placebo versus the steroid. You can see that the period dilatation index was better with the steroid. And this is the conclusion of this meta-analysis. Intralesion steroid injection increased the time between the endoscopic dilatation of benign refractory esophageal strictures. Mitomycin C for refractive benign esophageal strictures. It is derived from the streptomyces. It is anti-neoplastic and anti-proliferative. The technique is to apply it either with cotton blends or spray or injection, and you need to keep it for at least 1 to 5, and the mean is 2 minutes. So mitomycin, the results are really encouraging, better than the steroid. 24 studies, 45 patients. The mean follow-up 23 months, because most of the cases are caustic injury. You can see that 59% clinical response and 21 partial response. So it looks that mitomycin C, if it is available, is better than the steroids. Now, the other modality, if you failed, you can use the endoscopic incision therapy. This is a study comparing the incisions versus the bougie, and both of them showed the same bougie versus the incisions, which is they are equal in terms of the number of dilatations, success rate, and the time interval between dilatations. So if you have a patient who failed with the injections of all these things, what will be the next? The next will be a stent for refractory of benign esophageal stricture, usually only for refractory treatment. When you fail with dilatation and injection of steroids, you need to keep it at least 3 months. And the problem of these stents are the migrations. Overall effectiveness is unfortunately not more than 40%. The clinical outcome following a stent placement in refractory benign esophageal stricture. This is a systemic review and meta-analysis of 444 patients. They used, in this study, the meta-analysis, they reviewed all the stents, the fully covered plastic and the biodegradable stents. And you can see this result of this board clinical success is 40%, better with fully covered rather than biodegradable stents. And overall migration rate is 28, and less with the biodegradable stents. Now, one of the very important with fully covered is the migration rates. You can reduce the migration rates by many ways. One of the things is not to bridge the stent below the GE junctions. The other thing is you can use the over-the-scope clip or the suturing, but the through-the-scope clips usually will not hold the stent, and the stent will fall down. Some people try to use the lamps for those strictures, especially when they are short. The results are encouraging with a success rate of around 80%, but the migration rates improved to 80%. But the problem is that these stents with the big outer phalanx can cause fistula, and there are case reports of tracheoesophageal fistula, so you need to keep your mind. And I think these stents need to be modified, especially the outer phalanx, if you need to use them, the companies, for this purpose. So the ESG guidelines in 2016, they recommend against self-expanding methods as the first line for benign esophageal strictures. Consider the temporary stents for refractory, and they don't specify a certain stent better than the other, but their recommendation is not to use a partially covered stent because of the risk of removal after 3 months, and it will be a nightmare to remove those stents. So what will be the treatment if you fail? You have 2 other options: self-dilatation or surgical treatment. Self-dilatation therapy, old, but old is gold. This is a study, 17 patients. You can see the success rate is around 94%, and the ESG recommend to use it if you are failed. So this is the treatment algorithm for patient with benign severe strictures. If you have a patient with you dilated him with either bougie or balloon, more than 16 millimeter for 3 to 5 sessions, and you fail, then you are in the period of refractory. You can use dilatation with combined with injection of steroid or mitomycin C, or you can use incisional therapy. Then if you fail, you can go for stent placements. If you fail, you can go for self-dilatation or surgery. So to conclude my talk, refractory benign esophageal strictures remain a commonly encountered problem. Patient may need multimodality treatments. Patient may fail despite maximally aggressive efforts, and consider long-term stent for chronic treatment. Like our patients, finally, he responded well with the fully covered stents. And surgery is the last option, although most of the surgeons are often unenthusiastic to go to take those patients, especially if the stricture is post esophagectomy. Thank you.
Thank you, Khaled. You just finished on time also. Very good. I think I think you have dealing with it look like a simple subject, but it's you can give this, which is everyone see cases like that every day, but you give us an alternative. It's a very, very subject, and all the experts, when you said to them a case of ERCP or a case of benign stricture, you said an ERCP. Many of the professors, many of the experts, they don't like deal with the benign stricture because for me it's very difficult. And now there are, as Khaled said, there are many options for that, and he will give many examples how to manage. So thank you, Khaled, for this very nice, very practical lectures on benign stricture, and waiting for any questions.